Hello, welcome to the Global Frailty Network Frailty Seminar Series. My name is Sara Espinoza, and I am a geriatrician, and I am the director for the Center for Translational Geroscience at Cedars Sinai Medical Center in Los Angeles, California. Today, we have an interesting presentation about geroscience, and our panelists for today will be Dr. Isabel Rodriguez, myself, and Dr. Gustavo Duque. But before introducing the other panelists, I want to just give a few housekeeping issues. Please, during the presentation, use the WebEx chat button when you are asking any questions for any of the speakers today. And we will be kind of looking through those and then making sure we get those to the speakers at the end of all the three presentations. Now I'd like to introduce our other panelists for today. Dr. Isabel Rodriguez, MD, PhD, is a geriatrician and epidemiologist at the Clínico San Carlos University Hospital. She will be giving an introduction and overview of geroscience. Next, I will provide a general discussion about clinical trials in geroscience and focus primarily on a discussion of metformin. And then following my presentation, Dr. Gustavo Duque, who is a geriatrician and professor and chair of medicine at Western Health and Melbourne Medical School, will discuss other gerotherapeutic interventions and future directions for geroscience. Each panelist will have about 10 minutes to speak, and then we will have Q&A at the end of the presentations, all three of them. So with that, I'd like to turn it over to Dr. Rodriguez.
Well, so I'm Dr. Isabel Rodriguez. I'm a geriatrician, and today I'm going to talk about an overview of geroscience. First of all, I would like to thank to Dr. Reith to invite me to these Frailty seminars. So this is going to be the schedule of my presentation. First, I will talk about what is geroscience and their fields. After, I will continue with the relationship with between geroscience and frailty. After, I will talk about a little bit of the challenges of nowadays, specifically on the research, and I will finish with some conclusions. So in 2010, two very important facts took place. First of all, Spain won the Football World Cup, and additionally, Dr. Felipe Sierra, the Chilean biochemistry, started thinking or talking about geroscience with another scientific. Altogether, founded a geroscience group of interest in 2011, trying to promote the research on this field. Their hypothesis was that the slower we get older, the less loss of resiliency we will have as a result of the delay of the onset of some aging-related diseases. So geroscience is defined as the discipline whose main objective is to understand in both a molecular and cellular level the relationship between the biology of aging and the biology of the pathologies related to aging. Let's say that it will be an intersection between bioreontology and medicine. We all know that we have different trajectories of aging, you know, and all those three trajectories, like accelerated aging, normal aging, or successful aging, depends on two principal factors. First one, the environmental conditions, the healthy lifestyle, diet, exercise, habits. And the second one, and I think that is maybe the most important one, is the resilience, what means the capacity of our body to respond and adapt to those stressors. But of course, we are not young one day and the next day we are older, no? This have like a continuum between healthy status, geriatric syndromes, and the age-related pathologies. The main problem is that what we can see is the top of the iceberg. That is the clinical manifestation of all the molecular and cellular damage that has been accumulated along the years. So that is why it's very important to know, to study the mechanisms, the pathways that are underlying in that aging process. Biological aging is the main risk factor to accelerated aging, plus the presence of frailty, resilience, and the loss of function. But the good news is that all of them are modifiable. So if we have said that biological aging increases the morbidity, maybe our therapeutic targets have to focus on trying to compress the comorbidity and the loss on function. That's why, in this way, the principal objectives of this group of interest was to develop new research or new study designs with an appropriate animal models, more focused on health than on illness, and trying to develop some molecular and cellular biomarkers that could help us to identify those populations at risk of frailty in this case, or of having an accelerated aging. And what is the field of geroscience? A lot of them, okay, is frailty, that we were talking about that a little bit later, sarcopenia, osteoporosis, osteosarcopenia, cognitive disorders, cardiovascular health, metabolism disorders as well, cancer, or, for example, some nutrition disorders. So let's talk about the duality of geroscience and frailty. We know that aging has different stages. Okay, so the first one is the biological aging, in which we can see molecular damage and some alterations in the repair mechanisms. Okay, we were talking here about epigenetic alteration, senescence, loss of proteostasis, nutrient sensing, disorders in the mitochondria. After that, the second stage would be the phenotypic aging, which implies changes in body composition, some energetic inefficiency, some disbalance on the homeostatic mechanisms, and we could see sarcopenia, poor muscle quality, low fitness, changes in kidney or arterial stiffness. And the last one would be the functional aging that impacts directly on daily life. No, so here we could see decline on both cognitive and functional and physical function, mood disorders, mental health, and here maybe we could have a patient who is frailty, or who has disability or loss of autonomy. That is why it's very important to develop some biomarkers that could help us to identify those molecular damage, so that we can act, we can intervene in an early way. Through a lot of different molecular mechanisms and environmental triggers, like, for example, diet, infections, lifestyle, or some exposures, chronic inflammation can drive aging and age-related diseases, which in turn could exacerbate chronic inflammation, along with other hallmarks of aging that we are talking about that in a few minutes. With the updated of the hallmarks of aging, now we have 12, classifying 3 different groups. No? The first one would be the primary hallmarks of aging, which are telomere attrition, genomic instability, epigenetic alterations, loss of proteostasis, and disabled macroautophagy, that all of them are intrinsically negative and lead to molecular or cellular damage. These could be used to maybe monitor or evaluate an early stage of aging. Second, we have the antagonistic, that are the cellular senescence, mitochondrial dysfunction, and the regulated nutrient sensing, which they try at first to repair the damage made by the primary hallmarks of aging. The thing is that with as time goes by, and we don't know why, if it's incidentally or with prolonged pathway stimulation, they become harmful, and they participate in the aging process along with the primary hallmarks of aging. And the last one, there are the interactive hallmark of aging related to tissues homeostasis, that are the stem cell exhaustion, altered intercellular communication, chronic inflammation, and dysbiosis. And this could be used as a global aging rate. So in an ideal world, all those biomarkers could be used to assess aging different systems with a non-invasive way, and they could help us to predict mortality, illness related to aging, and functional decline. Now I'm going to show you some of the potential biomarkers that are proposed along all the literature. Some of them are related with hallmarks of aging, as for example, the micronucleus assay, that it could be associated with cancer, neurodegenerative diseases or frailty, telomere length, DNA methylation clocks, alteration in clustering of sortilin 1, or for example, the circulating osteogenic progenitors, or some relating with inflammation. It is true that there are a lot of them, but the most evidence that we have is with those related to inflammation, especially the RCP, interleukin 6, and TNF alpha. But we not only have those related with inflammation, but also some related with amino acid metabolism and gut microbiota, that is not only related with frailty, but also with sarcopenia, as we all know that both conditions have a common pathway. Again, this is another list of different potential biomarkers according to different hallmarks of aging. And additionally, we could also talk about some genomics and transcriptomics biomarkers, like for example, the expression of some genes or the telomere length. Additionally, there are some proteins that take part of the senescence process of some endothelial cells. Additionally, another related to metabolomics, like for example, lysina or valine, that are metabolites, or another non-omics biomarkers that we have already talked about. In this paper that I strongly recommend you to read, it is true that is not all the 12 hallmarks included, but only with the 9 classical one. But here there is a very, very good summary with all the biomarkers related with frailty according to different hallmarks of aging. So they classify according to if they are related to the genomic instability, with the telomere attrition, the epigenetic acceleration, the protostasis, stem cell exhaustion, etc., etc. So I think that to have a very good image in our head of the different biomarkers of frailty, this could be a very good paper to read. So as you have seen, there are a lot of different biomarkers, and there are a lot of different research that is still ongoing to develop and to identify new ones. But also we have said that now what we have to do is an early intervention to try to compress that comorbidity and that loss of function, no? So we have non-pharmacological interventions such as exercise, and pharmacological interventions with some senolytics or some NAD+ precursors. But what are the real challenges of nowadays, no? Especially in research? As a population is aging, of course, the prevalence of some age-related diseases is going to increase. And that's why we have to change our way of thinking and our way to design different studies, no? From a research point of view. So it is very important to first establish our outcome, trying to decide which one is going to be the outcome that we are going to assess and how, and the target population that we are going to use according to that outcome. Regarding to that, last year, some experts wrote in recommendation on geroscience research. So first, we have to set very well the population that we are going to focus our research. The people that is going to be more benefits of this is going to be pre-fail or early frail people, those that are at risk of losing intrinsic capacity, but they are still resilient. Second, we have to establish our primary objective that should be a one score combined of different items related to intrinsic capacity. Third, we have to develop and to establish a very good study variables according to resilience biomarkers, and trying to monitor the answer and adaptation to stress. And lastly, both the primary or secondary objective should be at least one of one, always something related to aging and resilience biomarker. And just to finish my talk, some messages to take home. Geroscience is the relationship between biology of aging and biology of illnesses. We could delay that biological substrate with identifying some biomarkers only more than always more than one. Okay, that could help us to develop the different therapeutic targets, both pharmacological and non-pharmacological. And what is very important right now is to change our mind, our way to design some research on geroscience, choosing properly the target population and additionally the main outcomes. Thank you very much.
So I'm going to talk a little bit about clinical trials. Although Isabel gave a very good introduction and overview about some of the issues related to geroscience guided clinical trials. And then I'm going to discuss more metformin, or focus more on metformin. So just by way of brief background, the field of geroscience is really founded in a lot of discoveries in the basic biology of aging, which Isabel already kind of talked about to some extent. And, you know, this actually is a very good paper from 2019 that kind of goes through sort of the history of going back to calorie restriction trials and so forth. But in 2009, I believe, is when rapamycin was the first pharmacologic agent found to extend lifespan through modification of the mTOR pathway. And there's been other studies that have shown other pharmacotherapeutics to extend lifespan in preclinical models. And that really kind of gave the foundation and moved us more towards testing some of these agents in clinical trials, especially some of the agents that were already FDA approved for other indications that could be safe, probably more safely tested in early trials in humans. So to date, there have been a fair number of small trials ongoing with lots of different agents, some that I kind of list here, and there's probably more than what I have here, and some agents kind of focusing on certain hallmarks of aging, but some of these agents likely impact multiple of these hallmarks of aging. And so honestly, it's a very exciting time in our field, I feel like, because, you know, 20 years ago, we were still doing mostly observational types of studies, and now we're moving into clinical trials. And again, it's very exciting time to be in this field. So this is a very, kind of detailed slide, but and it's a couple years old that I did this, but I reviewed kind of Geroscience guided type trials on clinicaltrials.gov and looked at the outcomes that are included, or the primary outcomes that were for these trials. And the outcomes really run the gamut, similar to what Isabel mentioned, from physical function to frailty, more physiologic function like VO2 max, etc. So there really, I guess, suffice it to say, there really is no one outcome for these types of clinical trials. And there's a lot of factors, I think, that go into selecting an outcome, and it has to do with the agent you're looking at, the particular hallmark of aging as well. So a lot of factors. So frailty is one of many possible outcomes for these trials. And there is some, I think, not some, there's a lot of discussion in the field about this. So we're still working on this in general as a field. But overall, our goal is to expand healthy lifespan. And, when the biology of aging work was initially done, there was always initially a lot of focus on lifespan. But in more recent 10, 20 years, there's been more and more focus on healthy lifespan. So not just extending lifespan, which is years of life, where you could potentially also inadvertently extend this period of illness and disability, such that your life is extended, but you still have a fair amount of your life spent with morbidity and disability. So ultimately, our goal is to extend this green portion of healthy life where there's really minimal morbidity and disability, and compressing that illness and disability towards the end of life. We may, through these studies, extend both lifespan and health span, and I think that would be a good thing if we could do that. But the overall goal is to extend health span. So I would just turn now to frailty as an outcome. As I mentioned, frailty is one of many possible outcomes for these trials. But we have been conducting a clinical trial of metformin for frailty prevention, really based on evidence that frailty is associated with heightened inflammation as well as insulin resistance, and also that inflammation and insulin resistance are known predictors of future frailty. And our initial hypothesis is that metformin can kind of impact or deter or reduce inflammation and insulin resistance, and by doing that, reduce the onset of frailty. I'm not going to go into a lot of the background about inflammation and insulin resistance associated with frailty, because I know we've had seminars in the past discussing that. But the evidence for metformin is based on preclinical studies showing increase in lifespan and health span in nematode and rodent models. Although this work, this is a bit controversial as well, because there have been other studies, some studies showing no difference in preclinical models, but there are a few showing extension in lifespan and health span. And then there are quite a number of observational human studies showing a potential benefit for metformin to reduce frailty, cancer, other diseases of aging, and also to extend lifespan. And this figures down on this slide are just showing some of the preclinical work, showing the mortality benefit in rodents, and then also improved treadmill and rotarod in metformin treated rodents compared to non-treated rodents. I'm probably going to skip this slide, but I'll just briefly say that we had some preliminary data in the VA showing that metformin in older adults with diabetes treated with metformin versus sulfonylurea reduced the onset of frailty and mortality over about 5.5 years. But as I mentioned, our initial hypothesis when we wrote the grant was mostly focused on inflammation and insulin resistance. But more and more information is coming out, or research about the mechanism of action of metformin. And it appears that metformin does have a lot of impacts on many other hallmarks of aging, such as mitochondria, cellular senescence, and epigenetics. So we actually are also studying some of these hallmarks of aging in this clinical trial that we are conducting. I'll just very briefly go over the trial design, but before I get there, I'll just say that we just finished the clinical phase of the trial and are completing data cleaning and starting the analysis. So we started this trial in 2017, I want to say, or 2018, around there. And we're getting very close to having some results. So I'm sorry I don't have any results for you right now, but stay tuned. But we focused on older adults with pre-diabetes in the study because there's a lot of evidence showing that people who are older adults with pre-diabetes are at higher risk for becoming frail. And we thought that this subgroup would be more responsive to a metformin intervention. And so the inclusion criteria were adults 65 and older who were not frail, community dwelling, and we based the frailty criteria based on the Freed criteria, and they had to be pre-diabetes as defined by impaired glucose tolerance based on an oral glucose tolerance test. And we really kind of modeled that on the diabetes prevention program entry criteria. And we excluded people with a mini mental state exam less than 24, or individuals with, I would say, severe neurologic, cardiopulmonary, or rheumatologic diseases. Well, actually, we excluded any rheumatologic disease, but people could have mild COPD, mild coronary disease, as long as it wasn't severe. And we've published the study design if you are interested in learning more about it. And we randomized individuals to metformin or placebo and followed them for 2 years. And we did pretty extensive evaluation prior to starting metformin or placebo, and then throughout the 2 years, which essentially included, of course, frailty measurements, which is our primary outcome, oral glucose tolerance tests every 6 months. We did insulin clamp and muscle biopsy at baseline and 12 and 24 months. And then, of course, safety labs and assessment of adverse events, as well as blood for inflammation and other markers every 6 months. So as I said, I don't have any results yet, hopefully very soon, but I'll just stop there and basically end by saying that we are in the process of conducting several trials. I'm focusing on metformin, but there are many trials in this space to improve health span. Frailty is a geriatric syndrome, which could be a useful outcome for these trials, and we're currently testing metformin for frailty outcome. And I will go ahead and stop there.
The idea, and again, I didn't have the chance to listen to the first talk, but the idea is just to give you a little bit of a glance of what we think will be the future. And I think Sara already did a very, very nice summary of what is a clear example of metformin and also frailty as an outcome. But basically, these are my conflicts of interest. Um, are the slides passing okay? Moving forward, yeah.
We still are on the first slide.
That was my concern.
Okay, there we are. Yes.
Okay, so
Oh,
let's
and
move to
now
the.
you're back. There you go. There. Yeah.
Okay. Okay, so I will go very quickly on this because again, my main interest, and I'm sure you're already familiar with this, or it has been shown already today, how the hallmarks of aging are a clear example of therapeutic targets, and we you know we discuss about how to move forward from this mechanism of aging and hallmarks of aging into interventions and clinical trials. We should first consider a couple of important concepts. One, that sometimes we can target more than one of these hallmarks of aging if we really want to treat several conditions, several geriatric syndromes, or at the same time we can develop new drugs, but as in the case of metformin, maybe we can repurpose some of the drugs that are already available for the treatment of chronic conditions. But something that I think is very important, I wanted to highlight today, is really what do we want to treat? Why are we? How do we want to use the geroscience approach to treat something? And the first question, and Sara already mentioned about it, is whether we are interested in treating aging. And that comes to a very philosophical question, whether aging is a disease and whether we are treating something when we are targeting longevity. And I totally agree with Sara that maybe what we are targeting or we define as aging is probably the years without disability, which should be our therapeutic target. Then the second question is, and this relates to a lot of different trials that are already completed or are being conducted, is whether we are using geroscience to treat diseases that mimic aging or occur during aging. And this is the typical case of diseases that have been presented as geroscience treatment, for instance, idiopathic pulmonary fibrosis, which is very, very rare disease, or some types of cancer. When we treat cancer using a geroscience approach, are we really treating, are we really talking about geroscience, or are we talking about the hallmarks of cancer? And then there is the concept that we and others have been adopting for a while, which is the concept of what about targeting multiple age-related chronic conditions that we can treat with one shot using therapeutic approaches that target several of these hallmarks of aging. And therefore, we and others have considered that maybe, and when we talk about frailty, maybe what we're talking about, or maybe frailty is a therapeutic target, maybe we're talking about a concept that the World Health Organization is very much interested on, which is the concept of intrinsic capacity, which seems to be not a synonym, but seems to be the definition and the major component of frailty as a biological entity. Why I say that is because we know the dimensions, the 5 dimensions that are involved in the intrinsic capacity notion, which is cognition, locomotion, sensory, vitality, and psychological. And these altogether, I think we all agree, are affected in people with frailty. So that has allowed us, our group, and I know I'm biased from the perspective of musculoskeletal approach, but we think that the musculoskeletal system, the muscle and bone connection, are probably a very nice example, as an example of an important target that when we try to improve muscle and bone mass and function, we are going to be able to impact not only cognition, because we know that muscle and bone are very important regulators of cognition. This has been in the recent years very well demonstrated by several groups, including Lillian Plotkin in Indiana University, who has shown the connection between bone and brain. Our group, in collaboration with a Norway group, have been able to demonstrate that link between sarcopenia and brain, and the bidirectional communication between muscle and brain. We think about the determinants of intrinsic capacity that are related to the musculoskeletal system. Then we can connect intrinsic capacity with cognition, with locomotion, with psychological alterations, and with vitality, particularly with locomotion and vitality, and who knows, maybe with sensory in the future. But at the same time, if we think about syndromes like osteosarcopenia, where people lose at the same time muscle and bone, that are very much predisposed to develop frailty, well, they also enter within a vicious cycle that involves activation of many of the hallmarks of aging. So the idea and our working hypothesis and overarching objective is that maybe targeting commonly altered hallmarks in muscle and bone could not only prevent and treat osteosarcopenia, considered as an occurrence of several chronic conditions, a couple of the age-related conditions, but also at the same time target several other age-related conditions, such as dementia, such as frailty, and cardiometabolic conditions. Again, because by losing muscle and bone, we represent our 65% of our body mass, we are most likely going to affect other systems and develop other conditions. So the opposite will be beneficial. And I'll give you just a couple of quick examples because, I'm more interested in the discussion and the questions that you may ask today, because we are trying to target several of those hallmarks. One of the typical examples is fat that infiltrates the muscle and bone with aging, particularly in osteoporosis and sarcopenia. And we have been able to identify several hallmarks of aging that are activated by fat, including metabolomic alterations, including telomere shortening, including lipotoxicity, including autophagy, dysfunctional autophagy, many mechanisms that maybe if we regulate that, if we reduce the capacity of the cells to produce fatty acids by using, in this case, for instance, an inhibitor of fatty acid synthase, we're going to be able to, for instance, in this case, prevent osteopenia in osteopenic mice or forectomized mice, recovering their bone mineral density and the bone quality, and at the same time improving their muscle. So we are targeting 3 or 4 of the hallmarks of aging, targeting one mechanism, fat infiltration, and then improving muscle and bone, and therefore preventing the occurrence of frailty. This is, again, I'm talking about the future, but it's not the long-term future. We're talking about the near future, when these discoveries are being translated into clinical trials, and we hope to observe some results soon. The second interesting concept, as you know, one of the hallmarks of aging, and something that is really very much affected in frailty, is the stem cells population and their capacity to differentiate. So we have been working on stem cells that are in the circulation, in the actual bloodstream, where we can collect them, we can isolate them, and we understand now much better them and compare them with bone marrow stromal cells or adipose-derived stromal cells. We know that these cells may have similar capacity to produce and develop muscle and bone. We know that when they are in low levels, we have frailty. Clinically, we have demonstrated that low levels of these stem cells. So here we have another hallmark of aging, stem cell exhaustion, that we can target, that we can collect those cells. And because we observe very low levels in people with low bone mineral density and low muscle function, then the idea will be to use COP cells as a treatment for osteosarcopenia and frailty, where we collect, and this is not new, these stem cell transfusions have been used for frailty in clinical trials. Joshua Farr and other groups Joshua Hare, sorry, have been demonstrating that is an effective intervention for frailty, at least safe intervention for frailty. And we are working on collecting not the bone marrow stromal cells that have been already collected and demonstrated, but the stromal cells, these COP cells that come from the circulation, collect them from young donors, expand them, and then infuse in all donors with frailty, and this is an ongoing trials. So this is not, these are a couple of examples. There are many examples of things that our groups or others are doing, trying to move forward into, again, not taking geroscience approaches to cancer of very rare diseases, but using geroscience approaches to osteosarcopenia and frailty. And I just wanted to share with you this paper which just came out, and I'm pretty sure you recognize many of these names. And the interesting thing is that they use a senolytic therapy to treat osteoporosis in postmenopausal women, or mostly to evaluate the role of this or the effect of this senolytic therapy on bone biomarkers. And this, so it's a geroscience approach with senolytics to treat chronic conditions such as osteoporosis. In this case, it's only osteoporosis. Unfortunately, they didn't look, they didn't look at the muscle function and muscle metabolism. But what is interesting is that they found that in this treatment had a relatively weak but interesting anabolic effect. They didn't have any effect on bone resorption, but it's something that is promissory, that this was published in a very nice journal, that sends the message to every one of us that targeting geroscience or using geroscience to target several chronic conditions probably is the future. So coming back to what we think is that we can use geroscience to treat this osteosarcopenia adverse condition, but at the same time, we have a concomitant beneficial impact on other conditions such as dementia, cognitive impairment, or cardiometabolic conditions. And at the same time, we can improve intrinsic capacity, which will be a major determinant of improvement in frail older persons. Before I leave, I want to invite all of you to attend the first scientific meeting of the Canadian Translational Geroscience Network, which will be held in here in Montreal in September 5 and 6. And again, I think we should move forward or move into the discussion. Thank you very much, and happy to start the conversation.
Great. Thank you so much. That was really wonderful. Um, well, before we start the Q&A, I just wanted to announce that this is the last presentation of the Frailty Seminar Series for this academic year, and we will be starting up again in September, and so there will be a new list of topics for next year. So thank you for participating. If you have any questions, please put them in the Q&A. I do see one question about hypertension, diabetes, and the fact that these differ among races, and what about genetics? I think this question might be related to the metformin trial that I discussed. So yes, you are correct that there will be differences in chronic diseases by race and ethnicity. In the trial that I'm conducting, we have, I believe it's about 35% Hispanic in the study, and the rest primarily non-Hispanic white. So we will, depending on the numbers, be able to look at maybe some ethnic differences there. But I agree that ethnicity and race are big factors and probably need a lot more study. In addition, other social determinants of health. And I have to say, I feel like in recent years, there's been a lot more work to look at the role of social determinants of health on hallmarks of aging. So I'll stop there, and I don't know if others have a comment about that topic at all. No, okay. I have another question here about why did I exclude patients with rheumatologic disease in my trial? That was primarily because we know patients with rheumatologic diseases like rheumatoid arthritis or lupus, for example, have higher prevalence of frailty and kind of a different trajectory of aging. And we wanted to pretty much focus on frailty, not specific to a certain disease process. So that was the main rationale. And in fact, in the kind of landmark paper by Freed and Jeremy Walston and others in 2001, when they defined the frailty phenotype, they did exclude also people with rheumatologic diseases from that design for similar reasons. We also know they would have more inflammation. So it was really more to reduce confounding in the design. Okay, let's see if there's other questions. I don't see any other comments or questions.
Sorry,
Oh,
Sara, you have in the chat one.
oh, I do? Another one?
Yeah, two, actually.
I think I answered both of those, I think.
Somebody's
Unless
asking me
oh.
something. Yeah.
Oh, I don't see it. I don't know if you guys can see it.
Well, they
In
say,
the chat.
yeah, it's indeed, very interesting. My question for Dr. Duque is osteosarcopenia and frailty are related. That means the prevalence of frailty in women should be way higher than men. Is this correct? So, this is interesting because the connection between osteosarcopenia and frailty, I mean, there is no doubt that osteosarcopenia is a pre-frail kind of a state. And there is a high occurrence of almost the identical prevalence of sarcopenia in men and women in many of the trials. But we know the osteoporosis component is much more prevalent in women. But once they start overlapping, there is no major difference. I mean, we have found, some groups have found that it's much higher prevalence of osteosarcopenia in women. We actually found it. But other groups have found that a very high prevalence of osteosarcopenia in men. So all this story to say, independent of what the prevalence is, we know that whoever has osteosarcopenia is a much higher risk of developing frailty. So interventions that only focus on the sarcopenia or interventions that only focus on the osteoporosis only work on half of the story. So that's why any intervention, particularly we're planning for the future of geroscience to treat and prevent frailty, we should target both tissues.
Thank you. I see now the chat. Sorry, different sections, but okay, I see it now. The one question about a role for treating non-diabetic patients, frail patients with metformin in the future. I potentially, I think we have to do more studies and more trials. There are other groups that are interested in studying metformin in not necessarily in insulin resistance, like the population that I'm studying. And so I mean, possibly, I think that remains to be seen. But we just need more trials. Oh, and then another question was the dose. Sorry, I did not mention that. So we started the study participants at 500 milligrams of metformin or placebo, double blinded, and we titrated up to their maximum tolerated dose of up to 2,000 milligrams per day. And this was the short acting metformin, not long acting. And so then the question about specific biomarkers which we should do to check for frailty in older adults routinely. I'll pass that to my colleagues.
Well, you see that now there are a lot of proposed biomarkers, but there is a lack of evidence of which one of them are the most recommended to do in the clinical practice. No, that there is not a guideline or something similar. No, I would say that if I have to choose one, maybe some inflammation-related biomarkers, but just because probably they are the most easy to do, like the most accessible to do in our clinical practice. But not yet. Actually, that is one of the things that we have to do right now, no, to try to develop a document to say in our comprehensive geriatric assessment, we have to do not only the functional, mental evaluation and so on, but also some biomarkers, and which one, no, which are going to give us or which one are going to identify the people at risk of frailty or whatever.
Great. Gustavo, you want to add anything?
Well, it's hard to talk about biomarkers in this condition. First, because we don't understand very well the condition, and second, because we don't understand very well the biology of the condition. So at the same time, a biomarker has to have a biological plausibility, which is something that, and I totally agree with Isabel, something that we have not reached. We have not reached the point where we can really demonstrate a biological plausibility that is specific for the frailty syndrome. A lot of these inflammatory markers are more specific for aging and probably inspecific for frailty. We don't know. Or, so the other thing is, what are we predicting? When we use the predictive value of a biomarker, I mean, they may have some kind of sensitivity and specificity that correlates with the condition, but what are we predicting? What are the outcomes that we are more associated or are more associated with frailty? We say, okay, frail older persons are much more high risk of fractures, let's say. So probably doing a bone mineral density is much better predictor than a biomarker for frailty. If we say, well, institutionalization, what is the best predictor of institutionalization in a frail older person? Probably is just the socioeconomic status or nutritional status or cognition. Yeah, so that's the difficulties that we are experiencing on biomarkers. So maybe the best biomarker for frailty at the end will be the quantification of the intrinsic capacity. Now that people are developing these constructs for intrinsic capacity, maybe we will have a much better definition of what we are talking about, something that we can really measure, has different components that at the same time we can target therapeutically, which is we will reach that point, and geroscience will play a very important role in that definition.
Thank you. There was, I think, one more question about does metformin improve all the aspects of frailty, or do we expect it to? So I should mention, for the outcome for the trial, we are looking at the Fried phenotype as well as the frailty index by deficit accumulation. And we will look at, the different components of the Fried phenotype. So I really didn't have a preconceived notion about one aspect, like characteristic changing more than the others, more focusing on sort of the total score, so to speak. So I don't know about that. I will say, though, that metformin does sometimes cause mild weight loss, typically 5% or less than initial body weight. So we did monitor patients' body weight closely throughout the trial, and accounted for that as in the metformin scoring. So that is one issue there as well. That's a bit of interesting little piece. But okay. I don't see any other questions. I don't know if you guys do. And I think we were asked by Dr. Ruiz to finish 3 minutes before the hour, and we are right on the dot. So thank you to my co-presenters for very wonderful presentations and interesting. Thank you to the attendees for very interesting questions and your attention and enthusiasm. And we'll see you in September at the next seminar.